My name is Martin Wakeham. I'm an assistant professor of pediatrics, Division of Critical Care in the Medical College of Wisconsin.
What is the role of nutritional support in the outcomes of critical care children?
Given the nature of their illness and life-saving therapies they are receiving, many children in the PICU are unable to have any intake of food on their own, much less what would be considered the regular intake of nutritional requirements. Therefore, these children depend on us, the team taking care of them, for providing them with the nutritional support they need. This could be achieved by nutrition provided via tubes, directly inserted into the stomach or into the small bowel, which is known as enteral nutrition, or via special solutions given intravenously. Enteral nutrition is advocated by most experts as the preferred way of providing such nutritional support. This way of nutrition has been shown by multiple studies to be safe and well tolerated in most critically ill children, and it has also been shown to improve protein and caloric deficits. A recently published study has shown that the intake of a higher percentage of a prescribed caloric target using the enteral route was associated with lower mortality. Unfortunately, many studies have shown multiple barriers to achieve adequate or optimal nutrition targets in critically ill children.
What was the goal of your study?
Our main objective was to examine the practice of early documentation of an estimated caloric requirement or target in the medical record of critical ill children and to see if this will have any effect on their daily calorie intake and the route of nutrition being used to provide them with nutritional support. We hypothesized that there will be a higher total daily calorie intake and more frequent use of enteral nutrition when a caloric requirement was estimated and documented in the medical record within 48 hours of PICU admission.
How did you gather your data?
Five pediatric intensive care units participated in our study. 4 of these units were located in independent children's hospitals, and 1 was part of a large community hospital. Our team collected and analyzed data from 2 sources: the medical records detailing the nutritional intake, including nutritional route, quantity, content, and presence or absence of an estimated caloric requirement of 1,349 patients who were admitted between January 1st of 2007 and December 31st of 2008. They were aged between 30 days and 18 years and remained in the pediatric intensive care unit for 96 hours or more. The other source of data was a multi-site clinical database dedicated to the data sharing and benchmarking among pediatric intensive care units. We also note the type of provider who entered an estimated caloric requirement when one was present.
What is the importance of caloric requirements, or CR, in a nutrition care plan, and what is the importance of CR documentation in the medical record?
Establishing a caloric requirement or target is a recommended part of any nutritional care plan. Available clinical guidelines for the nutritional support of critically ill adults and children recommend that these patients should have a nutritional assessment with the development of a nutrition care plan early in their course. Our study shows that a little more than 50% of the study population lack a documented caloric requirement or goal entered early in their medical records. This lack of documented caloric requirement was associated with a lower caloric intake and less likely use of the enteral route.
How could documenting a caloric requirement might influence the amount of caloric intake and the nutritional support route?
In order to explain the association between a documented caloric requirement and higher caloric intake, we must first look at the steps involved in the complex process of delivering care to any patient. One of the initial steps in this process is that in order to be treated or addressed, an issue must be recognized. The complexity of care and multiple therapies required by critically ill children might make nutrition and providing nutritional support a low priority for providers taking care of them. A caloric requirement documented in the medical record is evidence that at least a member of the healthcare delivery team included nutritional support or therapy in the treatment plan for that particular patient. Likewise, not having a caloric requirement present in the medical record might be evidence that the subject of nutrition therapy was never addressed in those patients. This could explain the lower daily calorie intake shown by those patients in our study. Another possible explanation is that even in those cases in which nutritional support is studied, not establishing a clear target may delay escalation and thus result in the lower caloric intake observed in these patients. Following the same thought, if there were clear intent to provide nutritional support as evidenced by a caloric requirement documented in the medical record, even the most children can successfully be enterally fed, it is not surprising that the presence of a documented caloric requirement was also associated with a higher rate of receiving enteral nutrition.
You state in your study that almost all of the caloric requirements present early in the medical records were entered by a registered dietitian. How does having a registered dietitian on the treatment team might impact patient care and outcomes?
Our findings illustrate the favorable and important impact that registered dietitians can have on the nutritional outcomes of pediatric intensive care unit patients. There are several possible reasons for this finding. First, there could be insufficient knowledge about nutrition in order to estimate caloric requirements among other pediatric intensive care unit providers. Studies have demonstrated that this is true among adult ICU providers. Second, even though there is growing evidence of the value of early nutrition, especially early enteral nutrition, for pediatric intensive care unit patients, there is still a lack of conclusive data on how such nutrition affects patient outcomes. Additionally, it is possible that while pediatric intensive care unit providers may have the knowledge to realize the importance of nutrition support, they may postpone nutrition therapy in deference to concentrate their time on other life-saving therapies. Our study is not the first evidence of the favorable effect that the presence of registered dietitians may have on the nutritional outcomes of critically ill patients. Other investigators have reported that following the hiring of a dedicated dietitian for their adult intensive care units, they had a more systematic recording of energy targets. More importantly, hiring the dietitian in addition to implementing a multidisciplinary nutritional protocol resulted in reduction of energy deficit and hospital length of stay. We would like to thank the Children's Hospital Association, formerly known as the National Association of Children's Hospital and Related Institutions, PICU Focus Group, which facilitated this study. We would also like to thank the participating centers, which include the Children's Hospital of Wisconsin in Milwaukee, Children's Mercy Hospital and Clinic in Kansas City, St. Joseph's Children's Hospital in Patterson, Corsair Children's Hospital in Louisville, and Mott Children's Hospital in Ann Arbor.